postpartum newborn, we'll do little short Kahoots to kind of just give a brief overview of sexuality, so we'll not stress about it. I promise it's fine. Today we're going to do posters and kind of review in between. Don't look at me like that. I'm not going to stand up here and talk about this for 5 hours or however long we're here. I like pretty posters. I need some new ones for my office, okay? So, you fine. Oh, if they have postpartum assessment, go first. All right, guys, here they go.
Okay, so we have postpartum assessment. We kind of broke it into two parts, physical and psychological. So first things first, we have discharge, aka lochia. If it's rubra, it's bright red. Serosa is pink/brown. Alba, it's yellow-white. We want to assess for hemorrhage. There's a very increased risk the first 2 to 3 hours after birth. You want to assess the incision site if there's a C-section. Assess the breasts, the bladder, bowels, and episiotomy if they had one. Extremities, like your lower extremities, so for like DVTs and stuff. And you want to reassess their blood pressure and blood sugar, especially if they had something like preeclampsia or pregnancy-induced hypertension or gestational diabetes. Of course, you want to assess pain. You want to check their fundus. And you want to get some kind of history from them as for their labor experience for their future patient history. Over here on psychological, we want to, of course, check their emotional status. They can have the blues. It's normal for less than 2 weeks. You can have depression, psychosis, and you really want to know what their support system is like after they get discharged out of there. And then, of course, we have a very unhappy uterus that's huffing and puffing, sobbing, and it's not one a funnel massage.
No, it doesn't. Especially if you had a C-section. All right, good job. So when you are doing postpartum assessment and for your test, remember your acronym BUBBLE, and that will tell you everything you have to assess. These are your notes too, by the way. So your first B is breast. What else should we inspect?
Size, shape, and color.
There you go. If a mom says, is asking about her milk, what comes first? Colostrum. It's thin, it's yellow, there's not tons of it, but it's just what baby needs in the beginning. Typically, when does milk come in?
3 to 5 days.
Yes. What is something we should educate mom on that can happen when their milk comes in?
It hurts.
What's that called? Engorgement. Yes. So when the breasts get engorged, they fill with milk. Whether that is, some people get engorged because it comes. If you have a mom who's not breastfeeding, her milk still may come in. If she's not breastfeeding and getting it out some way, she fills up. If a mom gets too engorged, a baby can't latch well. And if a baby can't latch well, they're not going to get a lot of milk, and we're just in this cycle. So we really need to work on mom feeding every 2 to 3 hours. One, that's going to stimulate her milk, and 2, that's going to help her with engorgement. If she gets engorged and baby can't latch very well, then we're going to have mom pump just a little bit, kind of relieve that engorgement just a tad. We can always give baby that milk back, and then baby will be able to latch, okay? We want to look for any signs of heat or redness. That could be a sign of mastitis. You also, sometimes mom might say, hey, I have this nodule. Sometimes the milk ducts can get clogged. So those are all kind of things that you want to be assessing for when you are assessing mom's breast. Okay? So uterus and fundus. It's probably our most important part of our assessment, okay? So the fundus is the top of the uterus. We talked about that this past week. If your uterus is not firming up, what is mom at risk for? Hemorrhage, okay? So it is so important that you're feeling that because it can happen pretty quick for a mom to hemorrhage. So we don't want that. Your uterus should descend about 1 centimeter a day back down into the pelvis where it belongs, okay? So, the exception to that is kind of right after delivery, somewhere 4 to 12 hours, it's gonna be about the level of the umbilicus. Then it kind of creeps back up just a little bit, and then it'll go back down to the level of umbilicus and start dropping 1 centimeter a day. Does that make sense? And usually, they'll tell you, like when a postpartum nurse comes in, the way they kind of feel is they do it by finger breadth. So they just feel for it and they say it's 1 finger breadth above, below, whether it's at, those types. So that's another way you may see it charted. They're not actually pulling out a measuring tape and measuring centimeters. So it is preferable. So if we go feel and it's boggy, what are we gonna do? We're gonna massage it, and we want it to firm up, okay? While you're massaging it, you're also looking at what's happening below. So how much blood is being expelled? Are there large clots? You wanna look under mom. Is there pooling underneath her, okay? You also wanna let mom know the first several times she gets up, she's going to, a lot of times they're gonna feel like a gush because it's pooling in there as she sits. So tell them not to be alarmed, that you're gonna have that sensation and it is to be expected, okay? So if the uterus is not firming up like we want it to, we may have to give mom some medicine. What can we give mom that will produce contractions? Pitocin. Same thing we gave them during delivery to make them contract. Let's see. What happens if you go to feel for it and it's not in the midline, it's off to the right and it's boggy? What distended bladder? We need to have mama TT. Yes, I have a 4-year-old. Okay, good. So what do you think about for bowels? So that's our other B. But no, it's just a B, a bladder.
May I ask a question?
Yes.
For the Pitocin, do you need like a doctor's order for that one?
Yes. So if you're not firming up with bundle massage, you're calling that provider ASAP. And some hospitals may have some kind of standing protocol. I don't think it would be on there for Pitocin, but it could be. There could be a protocol that says if you do this, and then you may start this as you notify the physician. So that would be something that you figure out if that's the area you want to work in. All right, we kind of talked about our bladder. So why do y'all think bladder distension causes our uterus not to contract? Because it's pushing on it. So the bladder, the uterus is trying to go down, and the bladder, if it's distended, it's pushing it back up, and so the uterus can't do what it wants to do. If mom is having retention, what do you think we're going to do? We're going to straighten it. So for bowels, we don't want mom to be constipated because she's already, whether we've had a C-section or a vaginal delivery, we don't want mom doing lots of bearing down, okay? So we're going to make sure that she's hydrated. Hydration also helps with breastfeeding. We want her to have high fiber foods. Most of the time we put them on a stool softener daily. What's the other issue moms can have that's kind of related to bowels in that area of the body? Hemorrhoids, okay? So they can do like the witch hazel pads. At Brookwood, they spent lots of money when they built their women's tower on these really fancy toilets that basically have like this built-in bidet. So you sit down and there's a little panel on the wall and you tell it where you want it to spray you, how, like it's fancy. I don't want to know what one of these toilets costs.
Only in L&D?
That is in Mother Baby.
Mother Baby?
Yes. So that's one thing they can do if they have hemorrhoids. It's kind of like its own little sitz bath sitting right there. That can help relieve it. Little sitz bath also helps with episiotomy. So how long would we expect a mom to have, for her lochia, the rubra, the bright red? So 1 to 3, 1 to 4 days. Then it should go to cirrhosis, so it's gonna be that pink tinge or brown. And then we will go to the alba, which is the creamy white or colorless. Typically, by 2-3 weeks, most of their discharge should be done with. But that's also something you would want to educate the patient on. So if we're having bright red discharge past the point that it's expected, that would be, we need to notify the provider kind of a thing. So for episiotomy, this was on your slides from intrapartum, but I'll show it again. Come on. There we go. So you can have a 1st-degree tear, and you can see it's just the vaginal mucosa. Your 2nd degree gets into some muscle. Your 3rd degree, you go further and you're down into your anal sphincter. And then your 4th degree, you were torn basically from your vaginal area all the way down into your rectum. And with each one, your muscular involvement can be more. So those are kind of your differences in 1st degree, 2nd degree, 3rd degree, 4th degree. I love it, yes. So it is better for a woman to have an episiotomy than to tear on her own, because we can control the episiotomy. We can kind of keep the edges cleaner, that kind of thing. So if a physician thinks that mom is struggling, baby's head is not going to fit without some significant tearing, that they're going to go ahead and make a decision to make an episiotomy, and then try to keep it as only what they need it to be. Does that make sense?
But what pushes them to make that decision?
If, as they're watching mom push and baby's head, if they feel like that mom's gonna tear as baby's head comes out, they're gonna do the episiotomy because it's more controlled.
So they'll do it during labor?
Yes. Yep. And then they sew it up afterwards, after the placenta comes out. What are some things, well, never mind, that goes to the next group, I'm gonna say that. Let's see. The other part of it is your lower extremities. So what are we concerned of with a mom, and why are we worried about assessing the lower extremities? DVT. Why are they at risk for DVTs?
Hypercoagulability.
Correct. Do you want to explain what that means?
Not really.
Not really. It's fine. It's fine. Throw out the big words. So yes, they do have hypercoagulability, which puts them at higher risk. We also have kept them down for a while, depending on how long labor was. So they've been off their feet. They've been, if they're vaginal birth, they've been up in stirrups. So their legs have kind of been in a position where it's really easy for blood to pool right here in the calf muscles. So all of those are risk factors to developing the DVT. So once mom, if she's had an epidural, gets feeling back in her legs and gets situated, we're gonna get her up. Like, we're really gonna encourage to get them up, get them walking. They're gonna have their STD hoses for a little while, those types of things, because we really wanna prevent a DVT, okay?
What's the STD hose?
The things, the compression things.
Oh,
They call-
SCD, not STD.
Oh, well, they used to call them STD hoses.
Oh.
Like, at Brooklyn, yes.
Yeah.
Y'all do SCD now, I think that's one.
Things like suction compression device.
Whatever,
But yeah.
Sorry, I was just, I wanted to
Go
clarify.
pee. Go get your pee. Go pee. Go pee.
Got it.
All right. In the back there. Okay, next group up. What are we gonna do to intervene and educate?
kinda fumbled a little bit. This is more like your assessment stuff instead of interventions really, so we're gonna adapt.
That's okay.
Don't hang this one up. So we did bubble, the HE's on the end. That's all your assessment stuff. We're just gonna.
Can I say one thing real quick, even though it was in your book? Don't ignore the home sign, because they don't recommend it anymore. It is not a good indicator of a DVT. Not saying you can't do it, but that's not like tried and true like they used to teach.
Okay, anyways,
Okay, but what would be your interventions for some of that assessment? Assessment is assessment, but sometimes, yes, it can be considered an intervention, I guess.
most of your interventions for all these assessments that they already talked about is gonna be to monitor them.
It is gonna be too long for that.
Interventions for your distended bladder, straight cath, bladder scan.
Okay, for episiotomy, what can we do to help relieve pain and discomfort? What can we
Heat
do?
packs, cold packs.
How long can you do a cold pack?
10 minutes?
Well, okay, after, let's put it this way, in the first, how long of a time frame are cold packs effective? Like, we would only wanna use them in the first
48 hours.
24 hours, and then after that,
Okay.
we'd swap to heat.
Okay. The peri bottle,
Your period, yeah, your sits, but yes,
area clean.
yep.
Your lochia, about how much the funnel massage can help that.
Yeah.
Your skin, assess your skin, and put your barrier creams on and whatever else.
Your bowels, I kinda talked about that, so we're gonna, get them drinking, we're gonna have high fiber food, we can get stool softeners,
There we go.
all those things. See, y'all got this.
Okay, we have energy level, activity, and fatigue. You want them up moving to help with all the other things, but balance. Pain assessment, make sure their pain is still controlled, make sure they're not coughing too hard, they've busted something. GI elimination, you should have a bowel movement 1 to 2 days after birth. Your fluid intake helps with your breast milk coming in, helps with your bowels. Your peripheral circulation with all your hoses and things. Education, early ambulation, safe sleep. Breastfeeding education is the pumping education, teaching mom to monitor how much lochia is normal, what acceptable clots are, what unacceptable clots are, your incision care. Yep, some women can have staples, so there's that. Other times it's stitches, other times it's glue. Signs and symptoms of postpartum depression. A lot of times they'll send like a postpartum depression education nurse in there to talk to you, make sure that you're like having good vibes with your child.
Vibes.
Yeah.
I like it, I like it.
Mhm.
Bonding, vibes,
Yep.
same thing, love it.
Your follow-up appointments, circumcision care if you want to do that for the baby. Educate on waiting to exercise and have sex. You have to wait like 5 to 8 weeks.
Yeah,
6 weeks
So we tell patients
before you can do it.
till they go back for their postpartum follow-up care.
There you go. No straw in C-section in your drink.
That's real.
Yeah, that's a real thing. Your education on your peri-care, like when you should be back to normal, all the things, sitz baths, or the fancy showers at Brookwood, the toilets.
Yeah.
You also need to wear a form bra if you were formula feeding. Firm bra, if you were formula
I don't know what a
feeding.
form bra is.
Yeah. Well, form bra.
I just had to mess with you. I did.
The type with the zipper in the front, y'all know.
Okay, no, you're talking about a mastectomy, like,
That's a firm bra, ain't it?
like it's compression.
That's what I'm saying.
Yeah, but we don't tell them they have to go get a zip-up bra for that.
A firm bra. Sorry, guys.
They just want something that, a little hold them in place, like,
Oh, and increase your protein and calories if you're breastfeeding, because the baby likes that stuff.
Yes.
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 Good job.
Thanks, Meg.
You did a great job.
Good job. We love you.
I love how it was a male and
had 12 kids.
No.
You go up there and talk.
Okay, she's only had 4, I think.
Yeah.
4? Okay.
So far.
Shut up.
She's a kangaroo.
All right, whoever said that, I give permission for Tiffany to smack.
No more.
Tiffany's
Same thing. Close enough.
I've never heard that in my life.
What? All right, good job, good job. Do you need anything? Well, they're just presenting their text.
She did last semester.
I guess 221.
Her NCLEX, you know, if they start doing some of them, I can tell them.
Okay.
I just didn't move it.
All right, so for education, one thing they had on here, I think we all kind of understand the ambulation part of it. What about safe sleep? What are we gonna tell mom while she's in the hospital?
Keep the baby on the back.
Keep baby on the back, but where else should baby be?
In the crib.
In the bass, yes, in their little bassinet.
Not by the door.
What is it?
Not to keep them like passing
I mean, that makes
doors.
sense.
I would keep it in between the bed and the window.
So I will say at least in Brookwood, because that's where I have the knowledge of their policies and procedures. Baby has to stay, she's right, on the opposite side of mom's bed, so not on the side that's closest to the door, the opposite side. Huh?
Baby napping?
Yes, yes, I was like baby napping or baby? Like napping, I was not sure. The other thing that a lot, at least at Brookwood, I'm just using this as an example because that's what I know. A lot of times if they say if mom is going to go to sleep and there is not another adult in the room, then they will take baby sometimes to nursery. So just know that there's lots of kind of safe stuff. With my 3 kids, I didn't see that a lot. I don't see that a lot when I'm taking students for clinical. Typically there's another person in the room, but I do know that if baby's awake and mom's falling asleep, and then they definitely don't want mom asleep holding baby in the bed. So, because we risk dropping baby, rolling, all those kinds of things. So if mom is getting sleepy, baby needs to go in their bassinet. What about postpartum depression versus baby blues? What are baby blues?
They go away.
They go away. They do go away.
Some of this stuff is like not while you're in the hospital.
Some of it is not. Some of it you can start seeing, but we still want to educate mom on it. So mom's body, everything got real up here while we were pregnant and delivering, and now it's kind of coming back down here. And so all that change in hormones, being tired, mom's body goes through a lot during pregnancy and to have a baby. Mom's body is tired, and now we're like, oh wait, I know you're exhausted, but now you have to care for a newborn, that is gonna rely on you every 2 to 3 hours around the clock. So you've got fatigue, you have hormone changes, you also have, and I know like when people say this, it sounds crazy and you might think that it sounds selfish, but it is true. Mom goes from being the focus to baby being the focus. And sometimes that's even the case for mom's significant other, spouse, whoever, all of a sudden, and mom still needs to be cared for. So sometimes even that can be hard on mom, going from, okay, everybody was all, I know it sounds bad, all about me while I was pregnant, to, okay, now everybody only cares about the baby, but I still need help and support. So all of that can kind of go into baby blues. It should not be, baby blues should not significantly affect bonding. It should not significantly affect activities of daily living, and it should pass. If it does not pass, if mom is having trouble bonding with baby, if mom is having trouble sleeping, like beyond we're getting up every 2 to 3 hours with baby, but even during those times where she could sleep, if she struggled to sleep, if she's having like significant mood swings, like we're going from way up here to way down here, and there's no in between, if we're struggling to find any kind of joy, then we're leading into depression. And that's when we really want to let patients know, hey, you need to contact your provider, because we don't want them to keep falling down that rabbit hole, okay? And then unfortunately, you do have postpartum psychosis, and a lot of times those are when you hear the horror stories of mom doing something that harms her and her children. And it's just because she gets in such a place that that's where her brain rationalizes that that's the way out. And we definitely don't want mom to get to that point. So lots of education on what is okay, because you also don't want mom to feel guilty. So let mom know what is okay, and then here's the point where we would want you to call us back, because this is kind of getting to where we think we want to help. Most of the time they do some sort of depression screening at their postpartum follow-up visit in the OB office. And I know in the pediatric offices, the several that I have worked in, those first few visits with newborn, when they come in, the pediatrician kind of does a depression screening with mom. So you should kind of have a couple of doctors with eyes on mom, kind of getting an idea how we're doing to try to catch this.
6 weeks.
The OB is 6 weeks. So, but that's why we need to do a lot of good education in the hospital, because we don't want them to feel like they have to struggle for those 6 weeks till they go see their OB, okay? Let's see. Okay, I talked about it, okay. Just know, I'm not gonna go into lots of detail, because this really gets more into even lactation that would handle this more than even the postpartum nurse. But if mom decides to formulate and not breastfeed, we still would wanna kind of get lactation on board. One, to kind of find out, not necessarily to pressure mom one way or the other, but why would you like to do this over this? And because sometimes people are just scared of breastfeeding. Well, I hear that it hurts, or I hear that it's hard. Well, yes, it is hard, or whatever. So sometimes just finding out the reason behind their decision, just like if somebody is refusing a medicine in the hospital. Okay, well, why don't you want to take this? Like, let's talk about it. Because it might just be education. It might just be, look, it doesn't matter what you say. I know all the ins and outs of breastfeeding. I just don't want to do it. Hey, cool, that's fine. Then we need to educate them about how best to go through the process of their milk drying up, okay? So lactation will kind of go through that process with them. And you will just kind of carry out the interventions that kind of lactation, not that there's tons that you would do while in the hospital, because sometimes their milk doesn't even come in until after they're home, but just know that you would want to get lactation on board either way. Let's see, let's do a few questions. See where y'all's head is at. All right, if we are assessing a uterine fundus after 48 hours after delivery, where would the fundus be? Or where would we anticipate it to be?
Wait, what'd you say?
48 hours after delivery, feeling for the fundus.
You want a measurement like
1
centimeters?
centimeter below the umbilicus.
So we would be 1 to 2 centimeters below the umbilicus.
Umbilicus.
Umbilicus, umbilicus, depending on.
Below?
Below. Because remember by,
Should we type these up?
they're in this book. That question goes 443. I'm not gonna put this question on the test if I'm asking you in class.
But you said that was, that was 4 to 11 hours?
48.
48.
48 hours, sorry.
1 to 2 centimeters below.
Yep. So just know it descends 1 centimeter a day is kind of your. This is not one that we talked about, but it is in your thing, in your workbook. Which of the following, okay, the nurse is educating a patient after delivery on the process of lactation and hormones. Which of the following does the nurse teach is responsible for the stimulation of lactation? Estrogen, prolactin, progesterone, or FSH? Prolactin is the hormone for stimulating lactation.
Stimulates.
Lactation.
Like prolactin?
Prolactin,
The hormone.
it stimulates lactation.
You see that's not a workbook?
Yep.
It's under definition.
If mom was RH negative, what would she be getting at? Rhodium. How do we give rhodium? It is, but I mean, like, we can give shots, and we have so few with intradermal, we have IM. It's an IM injection. And we're gonna give it within 72 hours of delivery.
When do you get the first round?
28 weeks, roughly. Okay, let's talk about this. So mom who's breastfeeding makes a statement that because she's breastfeeding and not having a period, she's safe from getting pregnant. True or false?
Wrong.
False.
Super wrong.
So,
That's how she got kids 11 and 12.
no, it.
Only the fourth one.
So, just because you're not having a period does not mean that you might not ovulate. So, depending on how well breastfeeding is going, your body, your hormones, because if the hormones get dropped to a certain level, then your body is going to go into the process of ovulating and having a period. But sometimes with breastfeeding, those go up and down, so you can come down enough that your body will ovulate, but not all the way to have a period. So, they need a backup form of contraception, okay? You can take birth control while you're breastfeeding, but it can only be certain one and only so much, because it can affect how much milk you produce. So that is not always a viable option. So you definitely need to let parents know that they can still get pregnant just even though mom is breastfeeding, okay? Okay. I think that's good. Okay. All right, let's go to our newborn. Let's assess them now.
newborn assessment, so the baby comes out, you wait till you can clamp and cut the cord. Depending on what baby's, how the baby is born. Like when mine was born, he was not crying. He was not breathing. So they literally took away from me. I did not have any skin to skin contact with my baby. So depending on how the baby comes out. So once the baby is out, every 1 and every 5 minutes, we are doing an APGAR score of the baby, which means that there's like a point system. So Ms. Tubbs, correct
Yes.
me if I'm wrong, but the APGAR score is supposed to be between 6 and 8, right? That's the normal healthy APGAR score that we're looking for?
No, we would want 8 to 10.
8 to 10, correct, okay,
Mhm.
so that's what I thought. Okay, so 8 to 10 is the one, so we're gonna go like all these, so activity. Well, we'll see if the baby is moving the arms, legs, flexing or not. And accordingly, you will score pulse. The baby pulses, the normal is 120 to 160. So we'll give the points accordingly. Grimace is if the baby is responding on stimulation. So sometimes baby is not making any sound, not moving. So maybe sometimes you have to tap the baby or, do your tickling or whatever. But, so you want to make sure that the baby is moving and prompting response on the stimulation. Appearance, blue, pale, if baby is cyanotic, baby has joints, yellowish color, any discoloration than the normal, you would rate it accordingly. Respirations, that's a biggie. So we need to make sure that the baby is crying good. And I think what we call is their nose flaring is a big sign. So if they are flaring, if you see their nose flaring a lot, which means that the baby is having trouble breathing, and that's when if the baby needs oxygen, I think that's an intervention, but yeah. So that's our newborn assessment, we do it every 1 minute and the 5 minutes. And then the other ones are the vital signs. They are very different than our vital signs. So as I said, our respiration, the temperature is always axillary. And the normal is 97.8 to 99. The pulse is between 120 to 160. They are breathing super hard. And the respiration, the normal is 30 to 60 because we know they are breathing very super fast. So that's the normal for them. Orostat, same as ours, 95 to 100%. We would also look into their gestational age, like at what age were they born? Were they pre, post, anything abnormal, then the gestational age is supposed to be looking for. So we need to check that. Physical assessment, again, general top, head to toe, how the head looks, skin color, any shape that you can see that's not the normal head shape that is supposed to be. Skin color, condition, posture, if you see any kind of deformities, I would say, in the baby. State of alertness, of course, baby crying, moving, all kind of stuff. Our respiratory status, I've already mentioned. If baby has any kind of a club foot, cleft palate, anything that needs to be, that's like an emergency or something. And then you want refluxes and the facial assessment. So, yep.
Huh, look at you. Who's the artist in this?
Her, that's why she picked
Well,
it.
no, I wrote it.
Her and Carson.
The
I like
artist.
it.
And then I did the prints, but that's besides.
Oh, you did it
Yeah,
right.
guys.
All right, so you will need to know an APGAR for your test. Just throwing that out there. Is it like a lab where you are given your normal values? Yes. Okay? But if I give you a scenario and I tell you baby is this, 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 and this, then I'm gonna say, what's the APGAR? I will give you the scoring rubric. You have to figure it out. Does that make sense? So you need to know the ins and outs and what things mean and what to look for to answer that question, but I will give you the normal. You don't have to memorize that bar chart, but you will have a question on it. So, I'll use my oldest child as an example. So, when he was born at 36 weeks, which some babies born at 36 weeks do great. He did not. He decided to be my problem child, and he has continued to be my medical problem child. But when he came out, he was flexed. So we want baby to be active, or we want them to be flexed. So they have been like this for 9 months. This is still normal for them. This is not normal. This is bad in baby. Okay? What we ideally want is them to be flexed but have some movement, like we're moving our arm, we're moving around, okay? But if they're just in the fetal position, that's kind of okay too. That's why we call this the fetal position. Pulse. Obviously, an absent pulse is really bad, okay? If it's below 100, then we need to do some things to intervene, kind of figure out why, okay? In an adult, typically, when do we initiate CPR? No pulse or no bleeding. That is not the case in a newborn. If their pulse rate gets below 100, then the conversation might, depending on other factors and what they're looking at, we may start CPR on a baby even with a pulse, because we need to get that heart rate back up to where we need it to be, okay? That's when the conversation's gonna start happening. I'm not saying that at 98 we're gonna initiate CPR, but we're gonna be taking measures, and if we're not getting baby's heart rate up, or it continues to drop, we're not gonna wait till there's no heartbeat to start CPR. Yes.
So respiratory rate is 120 or 110?
No,
Like,
your
how long?
heart rate
Yeah,
normal is
I know,
120 to
I'm
160. Your respiratory is 30 to 60.
30 to 60.
30 to 60.
120 or 110?
120 to 160.
That is 110 for fetal heart rate.
Yes. Is that what you're, yes.
I got it, yes.
Thank you. I was like, yes. So, in utero, you have a different range than once they're born. Is that where the confusion was coming in? Okay. And then typically the first temp we do in the delivery room is rectal. 1, yes, it's most accurate, but 2, we do it to verify that their anus is patent, that it's open. And then after that, we do it axillary, unless it's abnormal axillary, and then we're gonna do a rectal before we're calling the pediatrician. Okay? In the hospital, in postpartum, mom has a doctor, that's the OBGYN. Baby has a doctor, and that's the pediatrician. Most pediatricians round in the hospital. If a pediatrician does not round, then they are given to neonatology. They don't go to the NICU, but the neonatologist is who presumes care as the provider for that baby. Does that make sense? So you're not gonna call the OBGYN about a baby problem, and you're not gonna call the pediatrician about a mama problem. So they have, even though they have the same nurse, 2 different physicians that are gonna be taking care of them. So, going back to my sweet oldest baby, when he came out, he did cry. His heart rate was fine, but he was cyanotic around his mouth. His nares were flaring, and he was making this nice little grunting noise. My mom, I think I told y'all, my husband was overseas, so my mom was in the delivery room with me, and she was like, "Oh, listen to those sweet baby noises." I said, "That's not a sweet baby noise." I said, "Go over there and make that baby cry. Like, I don't care if you pinch him, go make him mad and make him cry." And she was like, "Why?" I said, "Because if he doesn't stop that sweet baby noise, he's going to the NICU." Well, as soon as he was blue here, what do you think they did? They popped pulse ox on him, and he was in the 80s. He was gone. So, and, you know, he's, like I said, he's proceeded to be my child that gives me heart palpitations sometimes when he gets sick. But anyway, so we went. He had no surfactant at all, so his lungs weren't opening up, doing what they were supposed to be doing, so we just needed some extra care for a little while. So anyway, grunting, flaring, retracting are your three big signs of respiratory distress in an infant, along with cyanosis, low pulse ox, those types of things. Where can you easily see retractions on a baby? Their stomach. So you can see up here, like you can see sometimes up here, but if you, in the delivery room, baby's naked. If you're on the floor and baby starts having problems, you want to undress them and look at that belly. Because what you're gonna see is it's gonna suck in, you're gonna see the ribs poke out, okay? In the delivery room, we're also gonna weigh baby. We're gonna do a head to toe length. They're gonna do a chest circumference, they're gonna get a head circumference. If baby is stable and mom is stable, where are we gonna put baby? We're gonna put skin to skin on mama. So basically, ideally what you would want is chest of baby to chest of mama. Okay? Does anybody know why skin to skin has become such a big part of postpartum care? It helps baby regulate. Baby will regulate temp, vital signs, blood sugar. It kind of helps mom's body get going, starts stimulating mom to start producing milk. Baby may go ahead in that first little bit and worm his or her way down to find mom's breast to start feeding. That's perfectly fine. They're gonna root. Let's see. I'm gonna let the other two groups present their poster, and then we're gonna go more in depth in the newborn, the PowerPoint, and all that kind of stuff. So, where's my intervention group? I'll let y'all present, and then we'll.
Okay, so we ended up doing a lot of more assessments than we should have.
It's okay. It's okay. No big deal.
Yeah.
Oh, look, don't have a cute. Look, they're
That's our baby.
friends. This one's a boy, that's a girl. Aw.
So we had physical assessment, which is the APGAR. They went over that. You can't have interventions without your assessments though. Like,
That is true.
if their APGAR is low, you know you're gonna have to suction baby or give oxygen, stimulate baby by rubbing it, drying it off.
Yep.
And you want the APGAR to be higher when they recheck in 5 minutes?
Yes. So even if you have one that was, let's say, because she was saying, like even at 1 minute, if we're at 7, I'm looking to see, are there interventions that need to be had, but I'm not totally concerned. What I'd be concerned is, are we still at 7 when we get to 5 minutes, or are we lower, okay? Now, if you start lower, then yes, we're gonna be intervening to get it up, but we are most concerned kind of, where are we after we've done some interventions at that 5-minute mark?
So then we have meds. The erythromycin eye ointment is, you know, in case mom has chlamydia, gonorrhea, or any other fun bacteria in the birth canal. The vitamin K shot is so that I forgot the name of the vitamin K bleeding syndrome. Is that it?
Something, but it's for coagulation.
Yeah. Just make sure their vitamin K is not so low that they will bleed out for no reason. And the Hep B vaccine, just, you know, start them off. Make sure they don't get it, right? For complications, you know, if you check and they are yellow, we're gonna do UV light for jaundice. Glucose monitoring for hypoglycemia in case they need sugar, I guess.
Yep. Yep.
Sorry, I didn't look into that one.
What can we give, what are 2 things we can give them if they were low?
Breast milk.
Breast milk or formula. If they were super low and and they weren't feeding, or they wasn't coming up with feeding, what else can we give them?
We do an IV.
You could do IV. Do IV glucose.
Say that again, if they're not getting enough what?
So, if their glucose is low, so if they're hypoglycemic, we're gonna try to feed them first. So give them breast milk or, formula. So if they're not coming up with that, or if they are so kind of lethargic and, that they're not really wanting to feed, then we give them IV glucose.
Right, we're gonna swaddle baby for thermoregulation. If the baby is having trouble latching, we're gonna have a lactation nurse consult. And then we're gonna have screenings that we're gonna set up. The PKU blood test, which is to check if they have phenylketonuria.
Yes, so now it used to be called well, that is still called PKU. The test used to be, we would just always refer to it as PKU. Now it is called a newborn screening, and it is a must. They have to have it done before they can leave the hospital. And it actually tests for multiple kind of errors in digestion. It also will test for sickle cell. It will test for congenital hypothyroidism. Oh, and there's one more thing, and I'm drawing blank, but it tests for several things. And then it's always repeated a month after. You also can't get it until they have had their first bottle or good nursing, because we need them to have protein in them for the PKU test to be accurate.
We're gonna screen for hearing,
Mm-hmm.
and we're also gonna check their bilirubin level.
Hey, y'all listen.
Okay, and then we'll also check the reflexes, which I guess is more of an assessment. So they're sucking, grasp, for tonic, then tonic neck, Babinski, which is the response to stroking the sole of the foot. Moro, which is stretching out arms to a startle. Rooting, which, you know, rooting around looking for food. I don't know how to say that one. Truncal incurvation.
Yep.
And then stepping.
Yep. Okay, good job. All right, I'm gonna let education come up and present, and then we'll do a good deep dive into baby. Huh?
Hillary wants to come home with
Somebody come home with a poster.
Safe sleep, eating schedule, follow up, bond, skin to skin. Don't breathe in their face, limit the visitors, wash your hands, don't shake the baby, safe sleep, SIDS kind of thing. Car seat and wet and dirty diapers. Education. Not all at once.
I like it. Hey, no, put it right there.
There you go.
Cute baby. Yep. I like it. I like it, don't shake the baby. You know, it's sad, but that does have to be a disclaimer there. So, cold and flu season. Can y'all think of something else that if mom had this, we would want to educate her on kissing baby and things like that?
Herpes.
Herpes. So if mom has a cold sore, so not necessarily genital herpes, but then we want to let mom know that you need to refrain from kissing baby, all those kinds of things until that's healed. Make sure good hand hygiene. So if she touches that, we need to wash our hands. So herpes and newborn baby don't mix very well at all, okay? So like if we know that baby has been exposed or showing signs, a lot of times they will start them on antivirals pretty quickly because baby can get septic pretty fast. So, but a lot of times because we go through life, and if I have a cold sore, do I really think a whole lot about it other than it annoys the mess out of me? No, I don't. So is mom in that moment really gonna be thinking her cold sore is that big of a deal? Probably not, so we need to make sure we educate. All right, so, kind of going back to the beginning, why do we give vitamin K? To help prevent bleeding. Okay, think about it. What, in an adult, if they are on a certain medication, if warfarin, we give vitamin K to what? Reverse the effects. So are we making them more likely to bleed or more likely to clot if we give vitamin K? Clot, okay? Babies are new. Look, a baby doesn't come out with everything fully functioning like it should as an adult. So baby takes time to develop clotting factors. Baby takes time to develop the bacteria we need in our intestines. All of those processes take time. So we give baby that vitamin K to kickstart that process in, okay? I wish I had emailed it to myself. Anyway, I may post it just for y'all to watch if I can get it on there. But there is a pediatrician that does a great job of really explaining why it's important.
Is it the one on Instagram? She lives in Florida.
Maybe short hair,
Short
kind of
hair,
heavy.
yes. I
Yes,
love her.
yes, she does a great job. It kind of explaining the importance and why we give babies vitamin K. Okay, unfortunately, it's kind of gotten lumped in to the vaccine. Like, why do we give baby all this? And it's really not a vaccine. It is a vitamin. Okay, it is literally vitamin K. That's all it is. So erythromycin ointment. So 60s, 70s, I don't know, maybe even the 50s, somewhere in there, they saw a rise in babies becoming blind from gonorrhea, chlamydia, those types of things. So that's when they started the institution of erythromycin ointment, and they saw that the blindness in babies go way down. So that's why we do that. Hepatitis B vaccine. I don't really know. I can't give y'all like a great rationale why now we give it in newborns, other than I do know it's been tested, it's been proven it's effective. It seems to do better when we give it to them, really get kind of immunity going. If mom has Hep B, then it provides protection for baby, but it is one of those things that slowly, because when Hep B first came out, we gave it to like teenagers, like 11, 12, 13, and it has slowly kind of come down in age of when it's recommended to be given.
So it just helps your immune system.
Well, it prevents you from getting Hep B, but like it does boost your, not your immune system, I didn't say that very well. Your immune system for Hep B. So it does what all other immunizations do, and that it's providing immunity for that. I can't say this happened, so this is why we give it to a baby, other than it's kind of been tested and shown as they have done studies. We feel like this is the ideal time to give it versus when we used to give it at 11, 12, and 13.
So with the eye cream, is it like every baby gets it?
Every baby gets it.
Okay.
You just do it without asking the parents. I feel like it's
They
just
give
done and I don't like.
They give consent for Hep B, and I think they have to give consent for vitamin K. I would have to look to see if it's all 50 states,
Yeah.
but there are states where it is law, they get erythromycin at birth.
Okay.
It's not all in Alabama, is it?
I'd have to say I'd have to go
It's more
look
like-
at all 50s. I'd have to go look, but there are some states that some of this is mandated like by law, but
But she asked for consent on all three.
okay. You probably don't remember. I vividly remember signing consent for Hep B for all three of my kids. Actually, I think my first two I declined Hep B. We did it in the pediatrician's office the first time, their first
Yeah.
visit. But anyway, my third one, I think we went and did it. But I don't specifically remember vitamin K, but it could have all been lumped in together, and for some reason, only Hep B sticks in my mind. But I did read somewhere when I was going through this that some states, it's like, you're gonna get erythromycin.
I mean, you're taking them to the pediatrician within the first week anyway,
Yeah.
you know?
And sometimes if this is where I stand, this is Miss Tubbs' personal whatever, I'm not gonna ask you this on a test. Am I a proponent for vaccination? Yes, I am. Do I feel like it's gonna make or break majority of the babies if they defer Hep B until they talk to the pediatrician? No, not at all. So if I'm in this situation, I'm not going to do lots of education and vaccine education regarding Hep B with my mom and that baby. I'm gonna punt that to the pediatrician. I'm gonna let the pediatrician know, hey, they declined it, they would like to talk to you further before doing it. Cause that pediatrician is gonna be well more versed in what to say and is more likely to kind of get mom on board and be able to answer her questions so mom can make a more informed decision than me as the labor and delivery nurse. So that is not a hill I'm gonna die on. Because like Martin said, they're gonna go see the pediatrician the first 1 to 2 weeks of life, so. Yes, ma'am.
I found that video and I sent it in our group meeting.
Oh, thank you, yes.
I love her.
I do too.
So.
Oh, I could just sit
She
and watch it.
explains things so well.
A pediatrician that explains things. And I just, anyway,
She's on
okay.
Instagram and probably all social media.
So, immediate needs, same as all of us. We need to have a paid airway, we need to be breathing, we need to be circulating. For babies, we also need to thermoregulate. Again, they are learning how to do things. Their little body has been in this very sheltered environment for 9 months, and now it comes out into this big environment, and so that body has to learn how to do things on its own. So thermoregulation is added to our ABCs when it comes to a baby. So real quick on circulation, I know we talked last week about when baby takes his first breath, our 3 shunts close. So our foramen ovale, it just closes. Do y'all know what happens to your ductus arteriosus and your ductus venosus?
No.
They turn into ligaments. They close and they become ligaments in your body. I just think that's really interesting. How long does it take?
Is it like test interesting or were you just like saying?
It is technically in your workbook.
Okay.
But I do think it's interesting. Am I gonna get that detailed on fetal circulation? Probably not on a test, but I technically could since I put it in your workbook.
Which ones were they? The ductus and
Your venosus and your 2 ductus, they become ligaments.
Like, how long does that take? Is it immediate or a couple weeks? I don't know. This is interesting.
It's a pretty quick process. If you look at literature, some things say that when baby takes the first breath, all of those things should close. Now, whether they immediately like form a ligament, I don't think so. I think that takes time. I don't think it's a long process. But babies who have like benign heart murmurs, it's because that foramen ovale hasn't closed, or one of these haven't closed right away. So they should close right away. They don't always. Most of the time, within the first 2 weeks, they're closed. So like, one of my kids had a murmur in the hospital. By the time we got the pediatrician did finish closing, we no longer had a murmur. So when they stay open, that's when we have issues, and that's, you send them on to cardiology and let them handle that. All right, so newborn assessment. I feel like we have talked about this enough. Does anybody have questions about an APGAR? Okay. So gestational age. So I'm not gonna put this on the test, but just know we have these nice little charts that help us kind of confirm, basically, is baby matching where they should for their gestational age, okay? And it just talks about their posture, things that how they can move their limbs certain ways, their arm wrinkle, just lots of different things. And obviously, the higher the gestational age, the more advanced they should be. We also look at this chart down here that kind of gives us an idea. If you come out and you only weigh 2,000 grams and you're over here, well, let's say 1,500, you're over here in your term, so 38 to 40 weeks, you're kind of considered small for your gestational age. So we also have this where we can plot. Now, if your big old baby and you're up here, like my husband who was 10'10", I'm pretty sure if they charted him on this chart, he was large for gestational age. Tiffany, do you have a question?
No, I was looking at a hangnail.
Oh, okay. No, you're fine. So we have multiple things that we can use to kind of let us know developmentally or where we should be for our gestational age, and size-wise are we where we should be for gestational age. Sometimes you just are a big baby or you're just a small baby. It might absolutely mean nothing, but we kind of want to know because sometimes there are certain things that we see more frequently for babies that fall into these categories. So that's why we kind of want to know those things. Okay? And then of course we want to know if they're preterm or postterm. So outside, APGAR is your quick assessment done in the delivery room. Okay? That's really about as far as assessment goes in the immediate moment after delivery. When we talk about big physical assessment, we're kind of talking about we have gotten to our postpartum unit or whatever, and this is when your postpartum nurse takes over. And they're doing their full head to toe on baby. So we're gonna look at skin color. Ideally, we want them to be pink. What if we looked at baby? What is it called if we notice their little hands and feet are blue, but the rest of the body's pink? Anybody know what the word is? Acrocyanosis. So that can be a normal finding. We just want it to go away, okay? If it's blue around the lips, that's circummoral cyanosis. We're worried about that, okay? Or if we were, of course, blue all over. But ideally, we want baby to be pink. If we're looking a little bit yellow, they should not come out at birth yellow. Jaundice is something that should develop over time. But we're gonna, if we start kind of seeing that they look yellow tinged, then we're gonna start kind of worrying what that bilirubin is. They're gonna check a bilirubin level on every baby, whether they look jaundice or not. But if we start looking jaundice pretty fast, we might check one sooner than we normally would. Other than their skin, where else are we gonna see jaundice? In their eyes. If we have an African American baby and we might not see it in their skin, we do have their eyes. Is there anywhere else you can look and see it? In their mouth, their palate. We want to kind of know is baby's state of alertness. So baby should be going through periods of being awake, alert, and then we have sleep time. So when baby is first born, not long after birth, they have their first period of reactivity where they're really alert, they're awake, they're ready to go. That is an ideal time to do your first feeding if it hasn't been done already. Because baby is, that's when they're firing all the neurons and we're ready to go. Then baby's gonna go through a sleep, a period of sleep. And usually they kind of sleep pretty hard. They've gone through it too, just like mama has. And then later they have a second period of reactivity. And again, that's a really good time. If we didn't have a great feeding the first time, that's when we should try again to really get baby to latch and get feeding going. After that, we should have just kind of your normal, baby wakes up, we feed, we poop, we pee, whatever, and then we're gonna go back to sleep. We're gonna look at respiratory status. So not only do we want to count their respirations, but we also want to ensure that they're not grunting, flaring, or retracting. We want even respirations. When I've had this mentioned to me, all three of my pediatric clinicals this time, they all talk about how hard it is to count respirations on a kid or a baby. Where's the best place to look?
Belly, the size of their belly.
Their belly. They're belly breathers. And then we're gonna look for any obvious congenital anomalies. And we will talk about some of those at the end. So there's just some pictures of skin color. So like we talked about posture, this is what we want. If baby is just like this, and just like, kind of how y'all are probably at the end of the day, or how I'm at the end of the day, like we just flop on our bed. We don't want baby to flop. Okay, we want baby to be all curled up and tight like this. So there you can see normal, that's flared, okay? And then kind of see how you can see in between each ribs? Those are retractions. So we can have, we've talked about this, you can have cleft palate, we can have club foot, they can have extra digits. So we're gonna really look at physical anomalies. We've talked about this, we're gonna measure their length, their weight, we do it at birth and then daily. Their head circumference typically is 1/4 of their newborn length, and usually your chest circumference is close to, if not equal to, your head circumference. We talked about temperature already, we've talked about your vital signs, so some skin conditions they can have. So this picture up here, this is your newborn rash, this is your erythema toxicum. It is benign, but they have red blotches, and then sometimes within those red blotches, they have like either white or little yellow, like little pustule looking things, almost like acne. This little friend right here has a hemangioma. Kind of a broad term for that is your nevus vasculosis. So we just kind of have a collection of dilated capillaries. Sometimes these go away on their own, but they can take years. If they don't go away on their own, a lot of times they'll get plastic surgery and stuff involved. But sometimes they can be like by the age of 5 go away, so they can take a while. Your nevus flammis is your port wine stain down here, which is this little baby. So it is flat, it's not raised. And it's just basically a malformation of capillaries. And again, it's one of those things, sometimes it goes away, sometimes it doesn't. The little white bumps on the nose, that's milia. And then these are Mongolian spots. And basically you have melanin that during embryonic development kind of pooled in areas, and so you just have a very deepening color of that skin because of the presence of melanin.
What was the one on the bottom left?
This one or this one?
Bottom left.
Nevus flammeus.
Yes,
Venus
or port
flammeus.
wine stain is your other term for it. And then our next slide, the little downy hair on babies is your lanugo. This is a stork bite or nevus simplex. And then down here you have your vernix. Why do you think babies are covered in this when they come out? What?
But they're like little fish.
Protecting.
They're like little fish. Okay, well, but fish were made to live in the water. We are not. So why do you think we have this?
That's just the goo from
It's
nasty birth.
no. It's on baby before baby comes through the canal. It's like waterproofing for the skin. Baby's been living in water for 9 months.
See a fish.
Except a fish doesn't need waterproofing because the fish has scales. So that's what that is. Do we give babies a bath right away? No. What are some reasons we don't? Say it loud. I heard lots of mumbling. So temperature. So we want to give them time to start thermoregulation, which is why we put them skin to skin. We also don't want to delay skin to skin, so we delay bath. Because it used to be basically baby came out, they did quick Apgars if baby was fine, they are whisking baby away to give baby a bath, and then bringing baby back to mama. And that's not the case. Now they delay bath till later. Alright, so let's talk about the head. So we want to palpate fontanelles. How many do you have? 2. So So one in the front, one in the back, we want them soft, flat, and open. Okay, we don't want them sunken in, and we don't want them bulging. We're gonna kind of palpate the skull. You should be able to feel your suture lines. So some common things that you can see. So molding is just, so our skulls are fused together, so our suture lines are together. The babies are open so that when they go through the birth canal, the skull can override each other to help baby get out, okay? So that's what molding is. It's basically a baby comes out, so kind of like your cone head babies. They can come out, and it's just because that's how that skull has molded. It's gonna fix itself on its own, okay? I never can say this word very well. Your caput sedate, that one, I'm not even gonna try. So that's our baby up here. So we have some fluid that has accumulated between your scalp and your skull. And usually that just can be from trauma coming through the canal. Your cephalohematoma, what do y'all think the collection in there is if it has hematoma? It's blood. And again, a lot of times those things go away on their own. We don't have to do anything, but we do want to watch it. What might we be concerned with that the cephalohematoma would put baby at risk for, because that's blood and our body will break down blood and create a byproduct? Nope. Well, I mean, yes, but no, that's not where I was. What is bilirubin? It's a byproduct or breakdown of red blood cells.
Oh, jaundice?
Yes. So we're gonna watch this baby, because if we have a collection of blood up here, as our body breaks it down, we're gonna be worried they're at higher risk for jaundice. And then microcephaly and macrocephaly. So we either have a small head or we have a big head. We tend to be more worried if you have a small head, because we worry about brain development. We worry about other congenital conditions, genetic defects. Sometimes, just like with small for gestational and large for gestational age, sometimes babies just have giant heads. And it other than being a miserable birth for mom, it doesn't really mean anything. Sometimes it can, but like I said, we are more worried that there are issues if you have a small head versus a large head. And then of course we're gonna look at our nose, all those kinds of things. Are we symmetric? Is our nose patent? We've already kind of talked about the palate. Are they able to have their sucking reflex? Are babies typically born with teeth? No, but they can, and they're called natal teeth.
Hear me out. I was convinced my kid was gonna be born with teeth.
You're not the first person that I've heard that's like been terrified that their child will be born with teeth, but yes, they can be.
In my head.
What is thrush?
Yeast in the mouth, and then it gets compressed.
Yes, yeast in the mouth. So either mom has it and mom gives it to baby, or baby somehow develops it and gives it to mom and mom's breastfeeding. So if one has it, we treat both. And then eyes, of course, are they where they're supposed to be? Ears. What congenital, or not congenital, what genetic condition, if they have low set ears, do we think about? Down syndrome. All right, just kind of some further, just going through literally your head to toe. All right, if we get down here and a baby has a pretty big dimple or a mass or a tuft of hair at the base of their spine, what do we worry about? The spina bifida.
They have what? Hair?
They can have a little tuft of hair, like, it looks abnormal. Like, we're not talking about just like little blonde hairs or something like that, but they literally have like a tuft. It's very odd looking. But yes, that's at risk for spina bifida.
Is it like actually hair? It just looks.
It literally is like, think about, I don't know, it's just like a little tuft of hair.
This is why we need pictures.
No, a lot of going to palpate and make sure that both testes are there. They're probably not gonna be down, you're gonna have to feel up for them. We want to look to see our position of our meatus, so we wanna make sure it's in the center of the head of the penis where it's supposed to be, not on top, not on bottom. Females, their vaginal area could be edematous, they can also have discharge, and that is perfectly normal, it's due to mom's hormones. It'll go away on its own, you just wanna reassure mom. Like I said, when we take that first temperature, we do it rectally to ensure that their anus is patent. We also want to ensure when we look at their genitalia that they are obviously male or obviously female, depending on what is to be expected. If it's ambiguous, then we're gonna start down a rabbit trail of genetic testing and things like that. And then extremities, do we have 2 of each? Are they the same, roughly the same length? Do we have full range of motion? All those types of things. All right, our reflexes. All right, sucking, pretty obvious. Anybody have any questions about the sucking reflex? Okay. Your Moro. So when when you suddenly lift baby up, I don't know if I want to try. So it's kind of funny. The arms and the legs extend, and then they abduct, and their thumb and their finger will spread and form like a C. It will go away. It's primitive. We don't do it anymore. As adults, we don't do it. It goes away. But that's kind of what it is. So they kind of go out, they come in, and they make that little C shape. Stepping. If you were to hold baby upright and have their feet where they can feel something underneath them, they're literally going to step or do little dance moves with their feet. So tonic neck, though, sometimes you see it as a fencing position is what they'll call it. So imagine somebody who fences like with a sword and kind of how they stand. So they're kind of like this as I fall out of my chair. So while they're laying, baby is supine. I always have to think about it. Their head is turned, and the extremities on the same side are straightened, and those on the opposite side are flexed. So we're like this. Does that make sense? Rooting, we've already talked about. So the way we test rooting is we're going to stroke their cheek, and we want them to turn towards our finger, the side that we're stroking. Babinski, they told you about, you stroke the bottom of their foot, and when you do that, their toes flare. Grasp is that sweet little, they're gonna wrap their little hand around your finger. It's the sweetest thing ever. We won't worry about that one. The other one that is not on there that really we test more is, what does this reflex look like? Startle. So, when we, suddenly touch them, whatever. Loud noise, all those things. Another one, I won't necessarily test you on this, is called doll's eyes. Y'all might talk about it too when you get to the fourth semester. So basically, if you move baby's head, their eyes should go opposite. So if my head is going this way, my eyes should go that way. Okay? And that just confirms that our brain stem is intact and functioning. Like I said, I won't test you on that because, well, I do think it's in your thing, but it's not up here on the slide, but that's what that is. We've already talked about that. General newborn care, again, they struggle with thermoregulation. In the delivery room, until if they're not on mama, they're under a radiant warmer. When they get in the room, we are gonna have mom, unless they're skin to skin or feeding or something like that, they need to be dressed. They can be dressed appropriately for the season. So if it is July in Alabama, we don't necessarily want baby in fleece pajamas. Baby can be in like one of those little cotton pant, one footy pajama kind of things. We're gonna have them swaddled in blankets. Again, we're not putting 1,000 blankets on baby, okay? Usually, rule of thumb is they can swaddle in 2 blankets. And like blankets, I mean like this, like the swaddle blankets, not the little cute fleece things and all that kind of thing. We wanna keep baby free from drafts. So a lot of times in the hospital, they will say ideally we would like for you to keep your room temperature at this for baby's sake. When they bathe baby on a radiant warmer so that baby doesn't get chilled. So one thing we worry about if baby starts dropping temp is we're also gonna check a glucose, because these two go very hand in hand together. So if baby's having to expend a lot of energy to keep a normal temp, they're using all of their glucose, so their blood sugar is gonna drop. If their blood sugars drop, they don't have the energy to keep their temperature up. So they go together, so we're checking them both when one of them is out of whack. We've kind of talked about this. They're gonna wait till, they're not gonna do this immediately. So usually sometime within the first 24 hours when they're gonna do bath. You want to wear gloves when you first bathe baby. Why would that be? To protect yourself, because we've come through either mom's abdomen with a C-section or we've come through the vaginal canal. So bodily fluids are still in baby, it's not been bathed, we wanna wear gloves. Get everything prepared beforehand, because we want to limit the time that baby is undressed. Like I said, we're gonna have a radiant warmer. We do not have to bathe babies daily. So this is probably the only bath the baby's gonna get in the hospital. And we need to educate parents. You don't have to go home and bathe baby every day. It's really not good for them to be bathed every day. You can kind of hit the high points with a baby wipe, but we don't have to bathe baby every day.
About how often though?
Just every few days. I mean, really, like once a week would be like, yeah, really not very often at first. And then no tub bath until the cord falls off and if it's a male, the circumcision is healed. And cord, I've been in some babies' cord falls off like right after they leave the hospital. Some can take up to 2 weeks to fall off. So it really varies baby by baby. But no submersion until that cord is off. All right, intake and output. So a breastfed baby typically feeds every 2 to 3 hours, but we tell parents to feed on demand. So if baby wakes up and it's only been an hour and a half, but is rooting and showing all of those signs, we're gonna put baby to rest and let baby eat, okay? At the beginning, you're gonna wake baby up. So if baby is in one of those good sleep cycles, even if they're sleeping great and you're thinking, oh, we don't wake a sleeping baby, if it's been 3 hours, we're waking up and feeding. For a formula baby, you can go a little bit longer, but we're not gonna let them go longer than 4 hours. Why can a formula baby go longer than a breastfed baby? So formula takes longer to digest than breast milk. Baby has to do more to break it down, so it stays with them longer. So in the very beginning, wet and dirty diapers. You want at least one wet and one dirty, or whatever day old they are, for the first couple of days. And then once mom's milk comes in, I guess I should say this for a breastfeeding baby. Once mom milk comes in, then we want to start getting to that 6 to 12, 1 to 2, sometimes 1 to 3 dirty diapers a day. For a formula baby, we want to see this output quicker than we would a breastfed baby, because we're not waiting on mom's milk to come in. They're getting what they should pretty quickly. And then meconium, which is this dark, thick, tarry mess that is the first baby's poop. Usually around day 3 is when it starts transitioning. And usually for breastfed babies, it's yellow and it's seedy poop. Formula's babies, it's a little bit more formed. It still can be yellow, but sometimes it's a little bit darker, more brown. This is diarrhea that's coming out the baby's back. This is stool that has some blood in it. And if we have a baby taking iron, sometimes it can have dark in it, just like that. Cord care, so we really just want to keep it clean. wanna keep the diaper folded down underneath the belly button. It used to be, I feel like they did this with my first one, and he was the only one they did this with, but it used to be that the rule of thumb is you would take a little alcohol swab while you're in the hospital, and you would go around the cord like once a shift to help dry it off, or dry it out so it would fall off faster. They don't really do that anymore, they just let it do it on its own. Basically, we just wanna keep that skin clean and dry, just like we would for anything else. The cord will dry up and fall off on its own. What are some things you think we wanna educate parents on to look for after the cord falls off? Or even while it's drying out? Infection, so what specifically? Drainage. So if they start having drainage, if there's a foul odor, if we start having like redness around the belly button. The other thing is after it falls off, if we're like 24, 48 hours and we're having oozing, they need to call the pediatrician. Because sometimes they have to go in with some silver nitrate or something like that and put it in the baby and dry it up the rest of the way to keep from oozing. Circumcision care. So most of the time now, they lidocaine baby up and then they perform the circumcision. The biggest thing you need to know as the nurse is we need to watch for bleeding, we need to watch for infection. You're gonna get a nice big tube of petroleum jelly, and with every diaper change, you're gonna put petroleum jelly. You're gonna douse penis, diaper area, all of that with it, so the diaper doesn't stick to it, okay? The other thing to kind of let parents know is typically, baby goes through a nice little sleep period after having a circumcision. So it's not uncommon for them to take a big nap afterwards. That is your newborn screen, that's what it looks like. So we prick their heel, and you have to put blood in these circles. And then all this is demographic information. We also do a hearing screen before they leave, and so you don't do that as a nurse. There's somebody that's contracted, they come in, they put these little things in baby's ear, and their little machine tells them if baby can hear or not. Bilirubin is done at least once prior to discharge, usually more than once, usually twice. Safety, so all hospitals have some kind of baby alarm stuff. So sometimes it's a monitor on their foot. Brookwood now, they're on their umbilical cord clamps is where their little safety alarm is. You're also gonna have armband. So mom will have her armband, and then mom and dad, partner, whoever is the other person there, they will have an armband that matches baby's armband. And like things we talked about before, you always want to keep baby away from the door, so on the opposite side of mom's bed. If mom is going to be sleeping and there's nobody else in the room, a lot of times they like for them to go to nursery, all those kinds of things. So we're gonna let them know when to follow up with the pediatrician. So this can vary. Typically within the first week is what is normal, but if you have a baby that has some jaundice issues, they literally may go to the pediatrician within 24 or 48 hours of being discharged home so that they can get another bilirubin level. We're going to reiterate how often they need to be feeding, how many wet and dirty diapers, because once a mom is at home, mom's not weighing baby every day unless they have scales at home. Our indicator for hydration and are they getting enough are wet and dirty diapers. Can they produce tears? Is there moist membranes inside their mouth? Those types of things. Bulb suctioning, kind of educating how to do it, when to do it. All babies have to go home in a car seat. The hospital has to see the car seat and the baby in it leaving the hospital. You cannot just carry baby out in your arms. Safe sleep practices, so we always want to lay baby on the back. What literature says, and I'm not going to get into any discussion about what we all do. What literature says is safest is back to sleep in their own crib, bassinet, whatever, their own bed, not co-sleeping with mom and dad. And then we also want to educate and promote bonding. So When baby's awake, then we're gonna feed, we wanna play with baby, we wanna talk to baby, and then especially if it's a first-time mom, because this doesn't work if you're a second-time mom, but sleep when baby's sleeping. So, we've kind of talked about this, so they can have just kind of what we call physiological jaundice. Very typical, you see it, it's usually day 1 through 3. Like we talked about, you have an immature liver, so we are not fully able to break everything down, so bilirubin levels get higher, and then we see the jaundice. So, here's how we get rid of it. So we're gonna get them to feed, because how do we get rid of bilirubin? They poop it out. So we wanna feed them so that they can start pooping. The other thing is we're gonna do phototherapy. This is my sweet oldest child right here. So he, told you, he causes me all kinds of issues. So he went under phototherapy. Do you know what happens if we leave bilirubin untreated? Yes. They can have neurological impacts. So this is a little chart that we chart on, and it kind of gives us an indication, is this baby at low risk for developing jaundice or having to go under phototherapy, and then you can see they have kind of intermediate and high. And this is a tool that can be used in conjunction with other things to decide when we need to initiate, if we need to initiate phototherapy.
What's the normal range?
So normal for, normal for us is less than 2. Like we want bilirubin very low. So very beginning, day 1, day 2, something like less than 6. Day like 2 and 3, less than 8, and then up to day 5, we would want it less than 12.
Do we need to know all those?
It's on your thing.
Can you say them again?
Yes, so let's say day 0 to day 1, less than 6. Day 1, day 2, less than 8.
Wait. So it's less than 8 at day 1, day 2, not 6?
Yeah. Well, I said to change the first ones. Let's say day 0, day 1. So like the day they're born and the day after. So say those 2 days, less than 6.
Okay.
Then less than 8 up to day 2, which would really be kind of like day 3 in our brain. Does that make sense? So like the day they're born would count as day 0.
So 0 to 1, less than 6.
Less than 6.
2, less than 8.
Yes, and then 2 to 5, less than 12. The next thing we worry about is hypoglycemia. So normal in a baby can be anywhere from like 30 to 100. If we're less than 30 in the first 72 hours is when we worry. So if it is a baby born to a mom that has gestational diabetes, they all are going to get a glucose check. Other than that, we're going to check it if it's indicated. So it's not like everybody goes around and gets a glucose check. So some things we look for, are they jittery? Are their temp low? Like I said, those 2 things go together. Are they lethargic? So are they not really wanting to wake up? Are they not eating? Those types of things. And then you can also see cyanosis and apnea. It is more frequent, as we talked about, in diabetic moms in our preterm, because they are less developed, so their body is still figuring this whole thing out. Babies that are small, so they've had some kind of growth restriction in the uterus, or if they are sick, so if they become septic. And we already talked about it. First thing we're going to try to do is we're going to try to feed them. So if it's really low, if we're kind of headed towards low, they may let baby breastfeed. If we're getting really low, if mom really wants to breastfeed, they will. Baby's gonna expend more energy, which is also glucose. So you can also give mom the option of donor milk, if that is available at the hospital they're at. So basically, moms can donate breast milk in a stream, just like blood is streamed. And so we can do that way, because we're gonna get glucose into baby faster, and they're still getting breast milk. If those are not options, or mom chooses to, or baby is already formula feeding, then we're just gonna give them formula. And then we're going to monitor frequently until baby is showing signs that it can keep us sure of. Worst case scenario, then baby will go to NICU and be put on an IV. Alright, so respiratory distress. See, he calls me all kinds of problems. That's mine. So, grunting, flaring, retracting, a lot of times it can be transient. So sometimes if everything else looks good, but we're just having this, and maybe our respiratory rate is high, it might take them to like transition nursery and give them some time, see if they work their way out of it. Since my little buddy right here decided to drop his O2 sats and become cyanotic, he got to go to the NICU, and he's on little baby CPAP right here. It is more common in preterms if there's some infection involved, and with C-section babies. Why do you think with C-section babies?
They don't push.
They don't get squeezed, which helps squeeze that fluid out of the lungs. So supportive care, we're gonna stimulate them, give them O2 if needed. We're gonna get them warm, and we're gonna do a real good thorough assessment to see if there's anything else going on. Let's see. We talked about that. Okay, this is the last little bit, then we'll do Kahoot, and then we'll be done. So, there are three little things we're gonna talk through here. So one is cerebral palsy. We're keeping this very surface level, okay? It's just part of your exemplars, and so, cerebral palsy, you can have, there are different types, and it all depends on what area of the brain is involved, how much of the brain is involved, is what is indicative of what symptoms you see, okay? It is non-progressive abnormal brain function. It can affect their motor function and their posture. A lot of times the cause is unknown, but some things that we do know that contribute to it are if they become hypoxic, either in utero or right after birth, toxins, sepsis, and then that word right there, the kernicterus, that is the fancy word for what happens if your bilirubin gets too high and affects your brain. It happens in about 2 of every 1,000 live births. And it can range from mild to severe. And this has nothing to do with mom's age. So a 19-year-old and a 37-year-old pregnant woman have the same risk factors for cerebral palsy. Age is not a factor. So I have taken care of children who they are nonverbal, they are on a G-tube for feeding, they are wheelchair bound, they have seizures from having CP. I have also, on the other end of the spectrum, worked with a guy who was a nurse and he has CP. So there is a huge range of CP and what it affects. So for him, he had a pretty significant stutter, and when he walked, one of his feet were kind of turned outwards, so he kind of had a weird awkward gait, kind of drug one of his legs. But he was a nurse. He was a phenomenal NICU nurse. And he actually went into NICU nursing because he was a NICU baby. Any questions about CP?
Do we need to know the different types?
No, I'm not going that depth into CP.
Like, when do you find out that your child has it?
So, if something happened in utero, a lot of times you know when they come out, we're seeing signs and symptoms. If it's something that happens after birth, then it's usually when that event happens, because they can be born normal and then something happened, like you can have a hypoxic event, or like an anoxic brain, something like that, and then we've developed CP.
So, like, an adult can have a high bilirubin, right?
Yes.
So, can an adult develop CP?
Well, with an adult, the likelihood that it gets to that level, because we're talking about like a bilirubin that's in the 20s. So, with an adult, hopefully we are doing things way before we get. Because with an adult, I cannot think, I'm not saying never, I cannot think of something like bilirubin does in a newborn, where it should drastically shoot from next to nothing up into the 20s.
Okay.
A newborn, within like the first week of life, some of them get way up there and have to be readmitted back into.
Body can't do what an adult's body can.
Correct.
Okay.
Because which obviously if an adult has issues with bilirubin, then there's something going on with our liver. But until our liver is completely kaput, we still have some function. But there's also, not to go too far down a rabbit hole, there are also very benign diseases that can elevate bilirubin off and on in adults. Like my husband has Gilbert syndrome. So there are times, like when we were dating, I got worried that, because we've been dating for a little while and I was in nursing school, so, you always think of like the worst case scenario. And so I was thinking like, okay, is he some kind of closet alcoholic and has like I was going down this road, and finally I had to ask him, I'd be like, do you know that your eyes are jaundiced? Like, do you know? And then he explained it to me. Because I'd never heard of Gilbert syndrome. But it's very benign, and when he gets stressed, his bilirubin goes up and his eyes get jaundiced. Anyway. So a lot of CP is around safety. So again, depending on the severity of it, like we said, if they have a G tube and they're being tube fed and all that, then we're definitely worried about aspiration. They can have issues with UTIs, especially if they're immobile and wheelchair bound. They can have falls and accidents. So most of these kids are on baclofen to kind of help relax those muscles. What do anticholinergics do? What are they going to help do? They're going to help dry things up. And then, of course, you're going to have lots of interdisciplinary care. So they're going to have PT, they're going to have OT, they're going to have GI, they might have dietary nutrition, so lots of involvement. Yes, ma'am?
What? Anticholinergics, what do you mean by helps dry things up?
So anticholinergics, they help dry up secretions in the body.
Oh.
That's one of their functions. Huh?
No.
Outside of baclofen, and I don't think I put a question on there about baclofen, but I will double check, only because we talked about it last semester. That would be the only medicine I would ask you about regarding something like this. Down syndrome. So this is genetic. You have an extra 21st chromosome. Your primary risk factor is advanced maternal age. What is advanced maternal age? 35.
Geriatric.
I know, it's mean. So Down syndrome also, you can kind of have a little bit of a range of severity. So they don't necessarily have all the complications, or they can. They do have intellectual disability, and they have altered facial features. So our ears are lower, they tend to be smaller. You can can kind of see that a lot of times they have larger foreheads, their eyes are offset, their noses sometimes are a little more flat, sometimes they have a little recessed chin. But oh my gosh, are they the sweetest babies. So our main goal is to support growth and development. So whatever their potential is, that's what we want to encourage it to be. So one of the most severe complications is they can have multiple cardiac defects. They can have issues with hearing and vision. Because of their recessed chin, their nose, all of that, they are at higher risk for having obstructive sleep apnea. And you also see a higher prevalence of leukemia in Down syndrome children. So they routinely, at least once a year, will have a CBC check. So, quick story. I had a Down syndrome little friend, and he was so funny. A lot of times Down syndrome kids are very kind, they are very social. That goes into part of education of parents because they will sometimes just talk and go that they think everybody's their buddy. But in addition to being very social, he was the biggest flirt there ever lived. And so one day in class, he was kind of being whatever. So, and I happened to be down there. So I was like, okay, will you come help me? And so I was taking him down the hallway at school, and I just was giving him some random task. So we're walking down, and in the hallway are standing two people. One was, I think, our bookkeeper, I can't remember, and some other very importantly dressed looking person. And so we're going, and he looks at this lady who he doesn't know. I don't know who she is. Like I said, she just was dressed looking very important. And he looks at her and he says, "Excuse me, you beautiful." And he does his head like that. Because he also, like, if he got mad at you, he would do like this. He had no hair to flip, but he flipped his hair. But anyway, just as sweet as he can be. They're so fun. But they, unfortunately, lots of things they can have issues with that are lifelong. So, you can do screening in the first trimester. Our screenings have gotten better, but it still can kind of give a false positive. So that is something that OBGYNs usually discuss with patients. Like, we can do this, but just if it comes back positive does not automatically mean that your child has Down syndrome. And if it's negative, it doesn't mean that your child doesn't have Down syndrome. But we can kind of test and screen. There are some things now as ultrasound is getting better. Sometimes we can see some characteristics on ultrasound. They usually will do a full genetic workup afterwards. Another hallmark sign outside of the facial features is they'll have a semi-crease. So if you look at your palm, your creases tend to look like this. In a Down syndrome kid, it goes all the way across. It's connected. So failure to thrive is the last thing we're going to talk about. So it's decreased growth. It's a very negative connotation with this diagnosis, but it can literally just be because the child has some kind of GI malabsorption issue and they can't absorb their nutrients. So it does not always mean that the child is being neglected or harmed. Is that a cause of failure to thrive? Yes. But again, there's a lot of negative connotation around that. But basically, we have a child who is either fallen off their growth curve, or they're not really ever getting to where they need to be, and they're staying in those bottom percentiles or even off the growth chart. So we want to figure out, what is the reasoning behind this? So is it something developmental? Is it something anatomical, physical with their GI system? Is it do they have severe GERD and they're just not able to keep anything down? Do they have cardiac or lung issues? So are we having to expend so much energy that we can't dealing with these kinds of issues and just kind of keeping our systems and organs functioning, that we can't put on weight. And then, of course, the last is neglect or abuse or poverty. So we want to kind of figure out what it is so that we can fix it. So usually if it's one of these up here, a lot of times they will end up at first sometimes with an NG tube and do feedings that way, and then end up with a G tube until we can figure it all out. If we're down here, social work DHR is involved. We just kind of went through that. They're gonna get weighed daily. We're gonna have parents keep up with food logs. As they are gaining strength and weight, we're gonna get PT and OT involved. Lots of education, all those types of things. All right, real quick. All right. So, true or false, sexuality only encompasses social aspects of our life. False. False. It encompasses all aspects of our life. Not fun. I want to see Ethan's name today. Okay. Name a risk factor for erectile dysfunction. This is select all that apply. Age 65? Yes or no?
Yes.
Smokes 1 pack of cigarettes a day?
Yes.
Yes. BMI of 40?
Yes.
BP of 119/70?
No.
No. Okay. What is compromised, think patho, in erectile dysfunction? Oh, yes, sorry. So perfusion of the corpus cavernosum, testicular function, penile muscle strength, urethral blood flow.
That's the first one.
Perfusion, yes.
Can you repeat that?
Perfusion of the corpus cavernosum. All right, 70-year-old male enters the ER with chest pain. Before giving nitro, what medication would you want to know if he was taking? Yes. Okay, your choices: bupropion, protonics, atorvastatin, or sildenafil. Why? Hypotension. True or false? An erection lasting longer than 4 hours is a medical emergency.
Yes.
True. That is part of your patient education for any male that is taking medicine for erectile dysfunction. What is a non-pharmacological treatment for dysmenorrhea? Exercise, reduce fluid intake to reduce bloating, ice pack to the abdomen, only medications will fix dysmenorrhea.
Could you repeat the option?
Okay, what is a non-pharmacological treatment for dysmenorrhea? Exercise, reduce fluid intake to reduce bloating, ice pack to the abdomen, or only medications will fix it? Exercise. Are we gonna do an ice pack? Or what are we gonna give? Heat. Do we wanna reduce fluid intake? No. Do we want to, if anything, increase it? What is dysmenorrhea for those who said we don't know what that word means? Painful periods. Exercise will help, yes. Okay, okay, there's a difference between like menstrual cramps and you still can function and do your activities of daily living versus I'm crumpled in the floor and I'm vomiting with periods and I can't function. We have, there are probably lots of people who fall into the dysmenorrhea category, and we just are told, well, you just drew the short end. Older female client reports no menstrual cycle in the last 6 months, and she's telling you that she is in menopause. What is the nurse's best response? You are definitely in menopause. Menopause isn't diagnosed until you've gone a year without a cycle. I think you may be pregnant. Are you sure you just haven't forgotten that you had a period? Correct. So you have to go a full year without a menstrual cycle before you technically are deemed menopause. Now, could they draw some blood work and probably pull labs and decide that? Yes. But the rule of thumb as far as a cycle is a whole year. More education is needed when a client states which exercise is best during menopause. Walking, weight training, swimming, Zumba. More education is needed when a client states which exercise is best. So we're asking, the client is wrong because they need more education. So which one of those is a wrong answer?
Weight training.
Walking, weight training, swimming, Zumba. Swimming. What does somebody with menopause need? What type of exercise? Weight bearing. Walking is weight bearing. Weight training is weight bearing. Zumba is weight bearing. You're on your feet. I don't even know. Infertility is typically diagnosed after how long of unprotected intercourse? 3, 6, 9, or 12 months? 12 months. A client is seeking contraceptives. What considerations should be part of the decision? Select all that apply. Adherence to regimen needed to be effective, so are they going to take it like they need to? Yes. Past medical history? Yes. The client's needs for contraception? And then what the patient's mom did for contraception. Do we hear what mom did?
That's weird. That's a weird question.
Well, not really. So let's talk about it. If you have had a DVT, do you need to be taking oral hormonal birth control? Or any hormonal birth control? No, because you're at higher risk to develop blood clots with birth control pills. If a client tells you, I plan on getting pregnant in the next year, but I want to wait a year, should we really put an IUD in them? Because they're good for 5. Okay, so that kind of stuff is that you need to think about.
But you said ask the patient what their mom did for birth control?
Yeah, that was the wrong answer.
No.
We don't care how what mom took.
That's a weird question to ask a patient.
But do you know how many of you probably will be like, well, my mom did this, so I should do this.
That's fair. Well, maybe that should be.
So, and then we need to know, like, if this person is saying, well, I'm supposed to take this and I'm supposed to take this, but I kind of forget, is a birth control pill really their best option? No, they're going to forget it. They're going to have a baby. They're going to have a baby. Or at least they're correct. Okay, I just kind of answered this. I'm skipping it. A female client is on an antibiotic. What education is needed regarding her birth control pills? There's nothing. Antibiotics don't affect birth control pills. Take your antibiotic and your birth control at the same time every day. You need to use a backup method of contraceptive while on antibiotics. Stop taking your birth control pills while you're on antibiotics. Backup methods, because some antibiotics make your birth control pills ineffective. So if this patient has these symptoms, which STI would we be worried about? They have purulent discharge from their urethral meatus. Gonorrhea, herpes, human papillomavirus, or syphilis. Gonorrhea. If a client is tested positive for gonorrhea, which other STI should they be tested for? Chlamydia. They are. and education. All partners should be tested since you were positive.
Yes.
Abstain from sexual intercourse until tests are negative for curable STIs. Must complete treatment and may need to be retested.
Yes.
Condoms are one of the only contraceptives that reduce the spread of STIs. Yes, so they are. Which STI, if left untreated, can cause dementia? Syphilis, HPV, gonorrhea, chlamydia. Syphilis. So in history, there is a king that they feel like has syphilis. Do y'all know who it was? Henry VIII. So the Anne Boleyn dude, the dude who like kept getting rid of his wives because they couldn't have sons when, jokes on your body, it's your fault. Yes, that's what he had, Henry VIII. Who knows if he really did, it's just, apparently he went on a great parade in life. Okay, do y'all have any questions about any of your sexuality content? Any questions about